In this lecture, we are going to discuss a cohort study, which is the other type of analytical study. And the main objective of this lecture is to know what are the differences between cohort study and case control study, and how can we assess the relationship or examine the relationship between the exposure to certain risk factor and the development of health problem. In cohort study, the starting point is people who are free from the disease. In case control, we mentioned that we are going to choose cases or disease in disease individual, and then we are going to ask about previous history of exposure and to see the risk of the disease among those who have previous exposure. While in cohort study, we are going to start with normal people who have no disease, and then they have certain exposure. We expose them to certain exposure, and then we are going to follow up them for a period of time, waiting for the result or the development of the health problem or change in the health status. So it is a prospective study. So it is important to know that we are going to start with people who have no disease, but they have exposure to certain risk factor. During the period of follow-up, so we are waiting for the development of the changes in the health status, whether development of the disease or complication of disease or death or complication of certain drug, for example, and to see the effectiveness of the vaccine. And we are going to examine them periodically to see the effect or the outcome of the exposure. So we have also two groups in the cohort study. The first group, exposed group, individual who have exposure to certain risk factor. The second group, the control group, they are a group of people who have no exposure to risk factor. There are two types of cohort study, which the most important one and the most widely used is the prospective cohort study, where we have a group of people who have no disease but they have exposure, and we are going to follow up in the future to see the development of the change in the health status, or we are waiting for the development of the outcome. While retrospective study, some people use the retrospective prospective study, where the part is carried out retrospectively by collecting existing data, and then the cohort is followed till the outcome until the study is developed. So the difference from this diagram, we can see the difference between the case control and between the cohort study. And in the cohort study, we are going to start with the cause or the risk factor or the exposure, and then waiting for the development of the outcome or the disease or the effect of the exposure. While in the case control, the red arrow, you can see the direction of the red arrow from right to the left. That means we are going to start with individuals who have the disease, and then we are going to ask them retrospectively about the exposure. So the concept of cohort study, we are going to take a group or cohort of people, where the cohort is defined as a group of people who share a common characteristics or experience within a defined period of time. So by the term cohort means that it is a group of people who are having or share the same characteristics regarding age or certain occupation or exposure to certain drug or vaccine or pregnancy, for example, the pregnancy for the total period of 9 months, if we take the same period of different women at the same time, so this is called also cohort. Or birth, individual, for example, who born in 2010, they are a cohort. Or those who are born in any year, they are regarded as a cohort. Or you as a medical student, each year of the medical school, they are regarded as a cohort. The first year, they are regarded as a cohort for the first year, because they are shared, they are sharing in the same exposure to the same subject, to the same exams, different environmental factors. So they are a cohort. And we are going to compare them with a group of people or the control who have no exposure, and they are so the control, they are different from the cohort group that they have no exposure to certain risk factor. So we have two groups. You see on the top, on the left, we have for example, a group of a smoker. So here the smoking is the exposure, and the second group in the down, on the left side, they are a group of people who are they have no exposure, they are not a smoker, and we are going to follow up for a period of time and waiting for the development of the disease. You can see the people on the right top, they are individuals who develop with two colors. That means they are people who develop the disease or change in the health status, while in the bottom also we have only one who developed the disease. So we are going to compare how many individuals from the exposed develop the disease compared to how many individuals from non-exposed group who also develop the health problem. So the most important elements in cohort study: first, selection of the study subjects, or the cohort or the group who are going to be or having the exposure to certain risk factor. And there are different type of cohort according to the type of the risk factor you want to study, or the exposure which you are going to study. And you are going to follow up this cohort for a period of time, and the period of time for follow-up also depends on the outcome which you want to study. For example, in Birmingham study, which is the well-known study, which took a long time of period of follow-up to study the risk factor for cardiovascular diseases, coronary heart diseases. So selected a group of, or we can't take a group of people who have a specific exposure. We can take from normal population who have certain exposure, or school children, for example. We can also regard them as a cohort, and if we want to study for certain exposure, or as we mentioned, medical school for each year, professional group, or a certain occupational group, a certain occupation. We are going to follow up them who have the risk of, for example, of exposure, whether chemical, physical, or other disease agent. So the first group, they are a cohort group who have certain exposure. While so we are going to take the data on exposure, which is either by interviewing the individual, or by questionnaire, for example, or by medical examination, or by doing examination, for example, or reviewing the record. For example, if we want to take the dose of radiation, for example, number of surgeries for the individual, for the doctor who had certain surgical operation, or detailed on medical treatment, or by doing medical examination, different medical examinations. The third step is selection of the comparison group, or the control. Also, the source of control is also either we can take internal comparison. For example, if we want, for example, to see the effect of, for example, smoking among the college group, college, in the college at the, for example, student college, college student, sorry, and we want to take, so we would divide them into two groups from the same group of the, for example, the second year, we divide them into smoker, non-smoker. So this is called internal comparison, or we can take, we can compare it with another group of people, for example, or students from other college, for example. So, and then we are going to compare. So either internal comparison or external comparison. The comparison with the rates of general population, for example, mortality experience of the exposed group is compared with mortality experience in other population, and we see the difference. We are going to follow these two groups, the control and the cohort or studied group. We are going to follow up them for a period of time, and the determination of the period of time depend on the disease which we are going to study. Maybe, for example, if you want to study the allergic, the exposure to certain allergen, so we are going to take people at the time of, for example, from at spring, where there is a large number of pollen and may cause allergy. So we take, for example, 3 months, for example. Or we are going, if we want to study, for example, the effect of long exposure, for example, asbestos. So we need long time to see the effect of asbestos for people who are occupationally exposed to the risk of asbestosis and may cause cancer. So the time of follow-up depend on the time of the health problem which we are going to estimate to estimate it. So the follow-up, during this period of follow-up, periodic examination, we are going to perform to see if there is any change, development of any change in the health status of the people, by either by also by reviewing physician at and hospital, or we take the records from the hospital, or routine surveillance or death. So different method of follow-up. Or in the developed countries, they use the mailed questionnaires or telephone calls or home visit in order to see the effect of exposure. After that, after the end of the period or the time of exposure, or at the end of the period of study, we are going to analyze the results which we got, and this include, or by estimation of the incidence rate, and the incidence rate among exposed and among non-exposed. So the first step in assessing the relationship between the exposure and the outcome is by measuring the incidence rate of the outcome, or the disease, or the change in the health status among those who have exposure and among those who have no exposure, and then we are going to estimate the risk. And this is by measuring the estimation of the risk by certain estimation, which is either by the relative risk or by the attributable risk. The benefit of cohort study, it is of value when exposure is rare. Sometimes if there are certain exposures which are very rare and we want to study the effect of this exposure, so we are going to perform cohort, although this may need long time, and this is one of the disadvantages which we are going to discuss. And also we can examine multiple effects of single exposure. Sometimes one exposure may cause different health problem or different side effects, so we can examine from single exposure, we can assess or occurrence of different multiple effects of the exposure. The important thing is it is going to measure the incidence rate among the exposed and non-exposed, and it is then we are going to measure the strength of association by the relative risk or by attributable risk. We mentioned that in the case control study, we cannot measure the incidence or the prevalence because we don't have a total population. We have a sample of cases. They have already developed the disease, and we compared them with control. While in cohort, we are going to have a population. We are going to decide a sample size. For example, school children, the second year in the school, or the first year in medical college. So we are going to have a population, and then we are going to measure the development of the outcome or the disease among this group, so we can estimate the incidence, and this is regarded an advantage for the cohort study. Also, it is good in estimation the dose response relationship. For example, if we take smoking as an example, as an exposure, we can divide the level of smoking or the dose of smoking. For example, 10 cigarettes per day, 20 cigarettes per day, and 30 cigarettes per day, and then we are going to divide to measure the strength of association among different doses of exposure. This is, as we mentioned previously, called the dose response relationship. Also, it is important in assessing the temporality, the time sequence, exposure, then the occurrence of the outcome, so that these are good example of what is called the criteria of association, which we have already discussed previously. The temporality or the time sequence. First exposure, then the occurrence of the disease. It allows testing of the hypothesis. We mentioned that the descriptive studies, such as the cross-section or the longitudinal study, we put a hypothesis that certain individuals who have the problem, they maybe have certain characteristic of exposure. So we are going to follow this group, and we are going to convince or confirm the association or not by cohort study. No selection bias. One of the disadvantage of case control study is the bias, which we are going to discuss it later on. So, but in cohort study, there is no bias in estimation, because we are going people, no disease, and then we are going to measure the outcome, while it is different from that of the in case control study. While the limitation of the prospective study of prospective cohort study, that there is no, sometimes it is not suitable for rare disease. We mentioned it is good to assess the association between certain risk factor or certain exposure which are rare, but the disadvantage, it need long time of follow-up. So this is not suitable, for example, for cancer. So because we need long period of time for the development of the disease, so it is better or more suitable to start with the disease and with the cases, such as in the case control, and then we compare it with the other control. Loss of experience of staff, loss of funds. It is expensive because it need period of follow-up, and so it is expensive. And when we involve a team of a group of researcher, we train them for certain examinations. Some of these team may be lost because of, for example, they retire or maybe resign, so or change their residency, change their residence. So it is sometimes we lose of some of these team, so it is expensive. Also, change in the environmental factors. Environmental factors, if we take certain exposures which is affected by the environment, so this may change in the level of exposure, and this may affect the occurrence of the disease. Also, if there are changes in the standard and the diagnostic methods or diagnostic criteria of disease, there is what is called the International Classification of Disease. But these are not stable, but they are changed every time. And so if there are changes in the criteria of the diagnosis of certain health problem which is under study, so this may cause discrepancy of the results. Also, the study itself may alter the participant behavior. Some people may change their behavior. For example, it is difficult for to control the behavior of people. So, for example, they change their behavior of smoking during the follow up. So this will affect the result. Also, the effect of the dropouts or attrition of problem, which some people they stop. They either died or left the country or migrate, or they stop. So they don't want to participate for more longer period. So this we will lose some of the exposed individual, and this will affect the result. Also, the ethical problems. When we are going to follow up people, it needs certain ethical principles, such as, for example, the ethical issue or should be, for example, take the informed consent of the people, whether they want to participate or not, or confidentiality, the about the information of the people. So this may be affect the involvement of people in the study. And in addition, it is, as we mentioned, it is expensive because it need follow up, and it may need a large number of finance. Also, it is time consuming. Some of the studies, especially for those certain diseases, it need long time of follow up. So it is really time consuming, such as in cancer studies, as we mentioned. For example, to explore or to be more understandable, we are going to take example. We are going to take, for example, group of if we want to assess the relationship between smoking of parents and the development of acute respiratory tract infection among children. If you remember, in the case control study, we have the same example, but we studied this relationship by starting with babies or children who have respiratory tract infection, and then we asked about the exposure, which was also the parent smoking. But in this case, in the cohort study, no, we are going to start with children for smoking, mother or father, parent smoking. Yani we are going to our cohort children, healthy children, but the parent are smokers, so they are exposed to they are exposing to the risk of smoking. So normal children have no respiratory tract infection, but they are exposing to smoking of parents, and we are going to compare them with the children where there is no history of smoking among their parents. So the studied group or the cohort, children under 5, normal, no disease, no respiratory infection, but their parents are smoker, while the second group or the control, also children under 5, but their parents are non-smoker. And then we took in this study, it involved 800 children where the parents are smoker, and 1200 children of non-smoking parents, and we are going to follow up for the winter, for example, for 6 months. And then we are going to find how many children for with the history of whose parents are smoking, they develop respiratory infection, and compare to the other group. So according to this study, during the period of follow-up, it has been found that 592 of the first group, the children for smoker parents, develop respiratory tract infection, compared to 636 of the second group, where they have no history of no smoking among their parents, and they develop respiratory tract infection. So how do this suggest that parent is predisposed to the infection, respiratory infection for children or not? So the first thing, we are going to transform these numbers into 2 by 2 table, the same thing as we have already done for for the case control study. The first thing, we are going to constructing a 2 by 2 table. In this time, we are going to start, if you see, according to the direction of the arrow from left to the right. If you remember in case control study, we start from above to the down, the cases and controls from above to the down, and the while in the cohort study, we are going to the from left to the right, the direction, in order to calculate the risk. So we are going to follow up those children who are exposed, to the parents or smoker parents, and then we are going to follow up them. We took 800 children and we follow up them for a period of time, and then we saw 596 individuals develop respiratory infection out of the total children 800. So we are going to measure the incidence of development of respiratory tract infection among those exposed children, while out from 1,200 children for non-smoker parents, 636 develop respiratory tract infection. So we are going to measure the incidence, which is 636 divided by 1,200 multiplied by 1,000, and then we are going to compare with the incidence rate of respiratory tract infection among the first group. So these A denoted into children who are exposed to the smoking and develop respiratory infection, while the B, they are exposed but they exposed to the risk factor but they don't develop the disease, and the C, they are the group of children who are they are not exposed to the risk factor, while the D, they develop the disease, while the D, they are individual who are exposed but to the risk factor but not develop the disease. So the analysis, first step, we are going to measure the incidence rate. The incidence rate, which is for the first group, it is equal to the number of children who develop respiratory infection among those who are exposed to smoking of the parents. So it is equal to 592 divided by the 800, and it is equal to 740 per thousand. That means that out of each 1,000 children whose parents are smoking, 740 individual will develop the acute respiratory infection, compared to the other group, who are the 636 divided by the 1,200 and multiplied by 1,000, and it is equal to 530. So by just looking to the incidence rate, we can see that the incidence rate of respiratory tract infection among children who are exposed to the smoking of the parent is higher than the incidence of respiratory tract infection among non-smoker parents. Then if we are going to measure the strength of association by calculation of the relative risk, and we mentioned that the relative risk is the ratio between the incidence rate among exposed and the incidence rate among non-exposed, and it is equal to 740 divided by 530, and it is equal to 1.4. That means that the risk of respiratory infection among children who are exposed to parental smoking is 1.4 times greater than the risk of infection among children not exposed to parental smoking. And you have already known, we have already discussed the how can we interpret the result of the relative risk. And we mentioned that if it is 1, so that means there is no relationship. If it is 1, so that means it is no relationship. While if it is less than 1, it is protective. While if it is more than 1, so it is risky. And as it is equivalent to the odds ratio in case control study. The second ratio we are rate we are going to measure is the attributable risk, which is equal to the incidence rate among exposed minus the incidence rate among non-exposed, to assess that, or to see which the difference represent the difference represent represent to the fraction of the risk that could be attributed to the exposure under study. That means how many, what is the fraction of the incidence of acute respiratory tract infection among children whose parents are smoking, and it is equal to 740 minus 530 and equal to 210 per thousand. That means if the parental smoking is removed, the incidence is this is that can be decreased by 210. So then we are going to measure the attributable risk reduction. That this one it means that the incidence of acute respiratory infection smoking is attributed to 210 among the incidence. Sources of control we have already mentioned. It is either we mentioned that either we take internal comparison by choosing from the same group, for example, from the same cohort. For example, from the second year in medical school, we can take smoker, non-smoker, or we can compare them with other group from other college or from the other population, or with the relative or with the neighbor, or total population, and if we take certain occupational exposure, we can take from occupational group. In comparison between the case control and the cohort study, we can see that in case control we need a small number of cases, while in cohort we need large number. The time it is short in case control because we have the cases and we are going to ask about the previous exposure, while for the cohort we need period of follow-up, so longer period of time. The case control is lower or cheaper than the cohort study. It is easier for the case control to organize the case control, while sometimes it is difficult for the cohort. Interpretation of the result, it is easier in the cohort rather than in the case control. The case control is more likely to be used for or useful in the rare diseases, while the cohort, it is very difficult, especially if the disease need a long period of exposure. The cohort is more important in the assessment of the risk for risk measurements, and also for the causal criteria. It is very useful if we use the cohort study. The risk to the subject, sometimes it is there is no risk for the case control because they have already exposed it previously, while in the cohort sometimes it's difficult to remove the exposure. So which kind of study we are going to choose? Generally, the case control studies are more common, but the cohort study, they are more convincing or in confirmation of the association. The case control study are common than the cohort, and because it is faster and it is cheaper. While the cohort study, it is more convincing for two reasons: that they provide better opportunity to establish cause-effect relationship, as we mentioned, the exposure, then the occurrence of the disease, which is that this is the time sequence or the temporality. And also it is important that the dose response relationship also we can estimate it from the cohort study. Sometimes in the case control study are more prone to certain study design problems, such as bias, which is not always present in the cohort study. The cohort study, they have also they have certain drawbacks, such as because we mentioned that it is expensive regarding finance, or it is need long time or time consuming, and they take long time because sometimes we need certain follow up for the development of the disease. Also, it is difficult because some of the people may be drop out from the study, and this will lead to for example, misreporting of the cases of the disease or the effect. So, for the reason of the dropout, some of the dropout means that some of the people they stop from participating in the study. So this will result in losing some person from the follow up. So this will affect the result of the study. So it is mentioned that it is most important to use because this will affect the denominator. It affects the denominator, so it is better to use the person year for the denominator. That mean person year. That mean we are going to take number of individuals multiplied by number of year of follow up, in order to have the exact or the actual estimation of the effect. Another important study is the experimental studies. The experimental studies, that means that we are introducing the exposure. For example, giving drugs or giving vaccination, and then we are going to follow to see the effect of this intervention. So the experimental study different from the observational study. This is by applying certain interventions, and then we are going to measure the effect of this intervention. So the goal of public health, as we mentioned, that the goal of public health is to modify or change in the natural history of the disease by decreasing the morbidity and mortality. So and this is done by certain interventions. So this may the question then become, how do we know which preventive and which therapeutic measure are most effective to achieve the goal? So we are going to perform what is called the experimental study by application certain interventions. So experimental studies sit at the top of the hierarchy of epidemiological study design. They are the best studies regarding if we are going to compare it with other epidemiological study, because they produce more valid result, and but the drawback, it is very expensive. So the best study to see the effect of certain intervention or evaluation of certain treatment or evaluation of the healthcare service or evaluation of certain program applied for the first time, for example. So the best thing is to choose the experimental study, but the drawback of this study is it is expensive. It can be viewed as also prospective cohort study. We apply certain intervention, and then we are going to follow up. The advantage, it is regarded as a gold standard of epidemiological research. So it is regarded the best epidemiological studies and high status of validity and can pick up small modest effects. So it is a have a good valid results. For example, James Lind identified the symptoms of a scurvy among sailors at sea after a little time, or for example as a month. So James Lind saw some of the sailors, they develop signs and symptoms of scurvy after a month of sailing. This is because of he found that the effect because of non-consumption of vegetable or fruit, and this was done and performed at the 18th century. And then so he took a small sample size of sailors, and then he gave them fruits or vitamin C, so they are immediately become better and the sign and symptom disappear in 6 days. So this is an interventional. He add vitamin C for sailors, and then it is they have immediately the sign and symptom are resolved. The potential use, it is used for evaluation of certain drugs or treatment by giving certain group of people giving them a drug and the other group giving them placebo, and see the effect of the two drugs. Also evaluation of a new medical technique or new medical procedure, and evaluation of a new screening program or techniques, and also evaluation of the delivery of different types of healthcare services. The problem in the experimental studies is the ethical points which must be considered. First, it should be beneficial. Any study should be beneficial, and it have beneficence for the people. And this is the first ethical issue, that beneficence. Then it should be of no harm. So it involved the ethical principles involved in the experimental study at the beneficence and the non-maleficence. So it should be of benefit for the people, and we should not harm the people who are exposed to with our intervention. Also, the participant should know what the experiment, what are the risks, what are the benefit, and they have the right to refuse or to accept to be involved in or participate in the study or not. So it need informed consent of the individual. They should have an idea about the risk and the benefit, and what is the experiment, what are the side effect, for example, and they should accept whether to participate or not. So we need what is called the informed consent. So the ethical principle or ethical issue involved in the experimental study involved the beneficence, non-maleficence, and the informed consent. Also, in addition, that the confidentiality, we should keep the secret of the individuals. So all these ethical principles are involved in the experimental study. Also, it is important that if unplanned, if there is any, if the one of the participant develop some complication during the period of the study, he should be excluded from the study. There are two types the clinical trials of the experimental studies, which are the clinical trials, where it is usually used to assess the efficacy of a new line or treatment, for example, a new drug. So we take two groups. One group have the new drug, sorry, and the other one have the placebo. Or we have a special technique in surgery, for example, or treatment. So we divide people into two groups. One have the first treatment or the standard treatment, and the other have the new treatment, and then we are going to measure. So we intervene with the individual in order to change waiting for the result of the effect. And then we are going to compare between the groups. For example, if we want to measure or to assess the medical or surgical treatment among individuals who have peptic ulcer, so we take two groups. One group of peptic ulcer, they have the surgical treatment, and the other group have the medical treatment, and then we are going to measure the differences. It is either a random allocation. We should in the clinical trial, there are we are going to allocate the individuals randomly or non-randomized. So there are two types. It is either randomized controlled trial or non-randomized controlled trial, and it is one of the example in which, when taking the sample, whether in random or non-random, and to be involved in the experiment. So the main advantage or disadvantage of the disease, we have already discussed it. It is the advantage is the prospective direction, and it is the ability sometimes to randomize the individuals, to choose the individuals randomly, and it examine the temporal sequence of the cause and the effect, or the time sequence, as in the same thing as in the cohort study. And but the problem, can control the extraneous variable. Sometimes we can control some of the exterior. We exclude some individual, and we put certain criteria for inclusion and for the criteria for exclusion, and it is regarded as the best evidence of causality. While the disadvantage, it is impossible sometimes to control the behavior of the people. Sometimes, for example, they don't want to participate. They stop during the period, and they during the period of the study, or in addition to the ethical constraints, and it is expensive. And thank you.